Thank you, Natalie. Thank you all for being here today. So Maha and I are going to talk about how people with type 1 diabetes can fast safely during Ramadan. We'll go over key challenges that you may face while fasting with type 1 diabetes and share some recommendations, some practical tips and strategies to help you make informed decisions and to help you manage your diabetes safely during Ramadan. So before diving into the specifics of managing type 1 diabetes during Ramadan, let's take a moment to understand what it is and what it entails. So it's the 9th month of the Islamic lunar calendar, and for Muslims, it's a time of fasting from dawn to dusk. And during this time, people abstain from all food and drink, including water. And the fast is not just about refraining from food, it's a deeply spiritual practice that aims to foster empathy for those who are less fortunate, that to increase self-discipline and overall strengthen one's connection to faith. In addition to fasting, Muslims also engage in increased prayer, reflection, charitable activities, and community gatherings. So fasting with type 1 diabetes adds an additional layer of complexity to diabetes management. First of all, eating mainly at night, so either early in the morning or in the evening, disrupts usual eating patterns as well as sleep patterns, which can have an impact on blood sugar levels and can cause unpredictable fluctuations. And so because of this, insulin regimens may need to be adjusted during this time period. It's also important to prepare ahead of time to fast safely, considering the increased risks of dehydration, of hypoglycemia, hyperglycemia, as well as ketoacidosis. There are other forms of non-religious fasting, often for weight or glucose management, but there are key differences that make religious fasting, and in this case during Ramadan, riskier for people with type 1 diabetes if we consider the absolute abstinence from food and drink. And one major difference is the restriction on water intake, which can increase the risk of dehydration. Another factor is if insulin isn't adjusted properly, blood sugar can drop too low during fasting hours, and that can lead to hypoglycemia. Or if there's an excessive sugar production by the liver, it can end up raising blood sugar levels, and that can increase also the risk of ketoacidosis. There's also a higher risk of hyperglycemia after fasting hours. So when you break the fast, if there are really large quantities of carbohydrates that are consumed, especially when first breaking the fast, as well as later meals throughout the evening, that can further cause rises in blood glucose levels. So it's very important to discuss your fasting plans with your healthcare team before that to ensure you can fast safely. That being said, the American Diabetes Association has general recommendations to help ensure safer religious fasting for people with diabetes. And these include a pre-fasting risk assessment. So this helps determine whether fasting is safe by generating a risk score that is based on individual factors like diabetes, glycemic management, history of complications. There's also recommendations for fasting focused education, and this is important to learn how to adjust, how to recognize signs of hypers, adjust insulin, staying hydrated outside of fasting hours, and just overall managing blood glucose to help minimize the risks. And there's the recommendations to assess and optimize the treatment plan well before fasting begins. So whether that is insulin doses, medication timing, if applicable, and overall diabetes management should be reviewed with the healthcare team and adjusted as needed to reduce the risk of hypos, dehydration, hypers, and ketoacidosis. Oh, so pre-fasting risk assessment is essential to increase the level of safety, and some of the elements that are used for risk calculation for people with diabetes who seek to fast during Ramadan. I mean, as you can see, having type 1 diabetes automatically increases the risk. A diabetes duration of 10 years and more is associated with higher risk of complications, history of hypoglycemia unawareness, especially if these are severe or frequent. The level of glycemic management as well is to be considered. So the A1C levels of glycated hemoglobin, the type of treatment that is used, especially if one is on multiple daily insulin injections, as well as the frequency of the self-monitoring of blood glucose levels. Other factors that can influence the safety of fasting with type 1 diabetes include having acute complications like ketoacidosis or chronic complications like kidney disease or nerve damage can make fasting riskier, especially if they're severe complications. Having other health conditions, pregnancy, fasting is riskier during pregnancy, especially if blood sugar levels aren't well controlled. Frailty or impaired cognition, physical or physically demanding work, so jobs that involve a lot of movement or heavy labor can increase the risk of hypo and dehydration. Past fasting experience, so if fasting during previous Ramadans led to complications or severe blood swings or blood sugar swings, it may not be safe to fast again, and as well as fasting for long hours. So, depending on the geographical location for the time of sunrise and sunset, fasting for 16 hours or more can further increase the risk of both high and low blood sugar levels. So pre-fasting education is important for people who wish to fast. That includes learning about the risks of hypos, the risks of dehydration, hyperglycemia, and ketoacidosis, learning about the importance of increasing the frequency of glucose monitoring during fasting hours, but also the timing of glucose monitoring is important. We tend to see the last few hours of fasting to be frequently associated with hypoglycemic events, as well as education on overall preparation and adjustment to the fasting routine, particularly when it comes to nutrition and medications. For nutritional guidance, during religious fasting, some people change their eating habits and overeat when breaking their fast. And in different communities, iftar meals are high in carbs and added sugar, and this can lead to sharp spikes in blood sugar levels. So, to reduce the risk of both high and low blood sugar, it's important to ensure that meals that are consumed during non-fasting hours are balanced meals. They include fiber-rich foods, complex carbohydrates like whole grains, whole wheat, legumes, things like that, avoiding added sugars and processed foods, especially when first breaking the fast, the first meal after breaking the fast, and drinking enough fluids. So it's important to discuss these changes with your healthcare team so that adjustments can be made to your current meals rather than introducing completely new options to make sure that your food is culturally relevant for you and to your tailored to your preferences. Insulin and medication schedules may need to be adjusted for fasting as well. So the dose of mealtime insulin, the prandial insulin, may be reduced for the meal before fasting begins, so the meal before dawn. And for other meals after sunset, mealtime insulin should usually be matched to carbohydrate intake, and Maha will go over more specific cases on that. For medications in general, those with a lower risk of hypoglycemia should be prioritized. And it's key to remember that individualized treatment is key and to always consult your healthcare team to tailor recommendations to your specific needs. And technology can also be a valuable tool for safer fasting. So we have continuous glucose monitoring or CGMs that can help track blood sugar trends throughout the fasting period, which is especially important for those that are higher risk. Insulin pumps have been linked to lower rates of hypos. Because they allow for more precise insulin adjustments. So technology can be considered alongside risk assessment and meal planning and diabetes education to help make fasting safer and more manageable during Ramadan. So now I will hand it over to Maha to go over some practical applications.
Hi, everyone. Thank you for being with us. Asma went through general things. Now we're gonna go specifically to what you're using and what we can do to make it to make Ramadan happening for you. So we're gonna start with, oops. So we're going to start with those who are using the intensive insulin therapy. That means injecting basal insulin and rapid acting insulin for the meals. So we're going to start with the basal. If you are using premixed insulin, it's very dangerous, like higher, very high risk of hypoglycemia related to those insulins. So we need to change them for a basal prandial style of treatment. That means a long-acting one, the night, usually we call it the night insulin, and then the rapid-acting insulin, what we call prandial. This is the one you take before each meal, or you correct your blood sugars if it's high with it. Now, if we're having the basal insulin, it's important to reduce it 10 to 30%. So it's going to depend on if we're starting with a diabetes management on the higher end, let's say 10, 12, 13 blood sugars, versus on the lower end, let's say you're in the target most of the day. So the reduction is going to be different. So we arrange it between 10 and 30%. Don't hesitate to talk about it with your team. If you are using still NPH or Humulin N, those are insulins that we're going to have to change for those who are the newest on the market with less risk of hypoglycemia that we saw, so Toujeo or Tresiba. So it's very important to change the NPH because how this insulin works, it has like a action peak and higher risk of low blood sugars. Now, we have to be careful with how the insulin works. So with the Tresiba or the Toujeo, we need to plan it 2, 3, 4 days in advance. So the reduction of the dose has to be in advance because those are insulins that lasts 2 to 3 days. So the new dose that you're taking takes 2, 3 days to kick in. If you're using Basaglar, this is an insulin that we can change every day if we want to, depending on the situation. And in particular cases, I could also split that dose of Basaglar, and we take a bit in the morning to cover less during the day and higher in the evening, because this is where we have a little bit more carbohydrates. So it could come and help us with the prolonged digestion. So please talk about it with your team. There's many, 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 many options that we can work around. We're going to make it happen for you to be able to do the fasting. Now, for the prandial insulin, so the insulin that you take on the meals, those are usually Apidra, Trurapi, Admelog, Fiasp, Humalog, or Novorapid. So those, or Christi, this is a new one too. So those are insulins that we take for the meals or to correct. So if we're breaking the fast in the evening with the iftar, we take the insulin before eating. And then depending on if you're having a small meal, a medium meal, a bigger meal, the dose of insulin there has to be moved and changed based on how much carbohydrates you're having. If you're not carb counting, it's very possible to give you dosages based on how big the meal is. So talk with your dietitian and with your teams to be able to adapt that for you. Now, even if we adapt the dose before the meal, it's very possible that the blood sugar will rise and stay on the higher end throughout the night. And this is caused by a higher fat intake, fried food, desserts, and those fat increases insulin resistance. So for the same food, we need a bit more insulin. And to make it trickier, that insulin, we don't need it right away before the meal. We have to spread it out throughout the evening to mimic the delayed digestion provoked by the higher fat intake. So it could look like corrections that you're taking throughout the night, or a split dose, what we call a split dose before, and then 2, 3, 4 hours after, you take an extra dose of insulin to compensate for the digestion of the carbs that is still coming in. For the meal of the morning, we take the insulin before eating the meal, so that's not going to change. but we have to be careful with the dose because we don't want the blood sugar to go down and then you forcing you to break the fasting. So be careful. And it could be the first day you'll stay at 13 all day. It's okay. And then the next day you can readjust accordingly and take a bit more. So go slowly but surely so you don't have to pay the price and have a hypoglycemia. Now, during the day, it's very important not to take your insulin at lunch. So I do have patients telling me, yeah, I don't eat, but I take my dose because the doctor told me to take it. So no meal, no insulin. Okay, so that's very, very important. But if you have a meal at midnight, because it's your third meal, let's say you have it in the evening and then at midnight and then in the morning to make your 3 meals a day, then you have to take a dose at midnight. So we don't take the dose, but let's say your blood sugar is high during the day, you can use your correction factor. We can make it also looser so you don't go low. And it's very important when you're correcting to make sure you have at least 4 hours between each correction so we don't have what we call insulin stacking. So the dosages, they come one on top of the other, increasing your risk of low blood sugars. So this is just an example. Those are on injections. It's a bit tougher. Usually with Tresiba and Toujeo, it's easier. It's flatter. The insulins are really stable, but it's the rapid acting. We never know how the body's going to react. We never know if the liver is going to overproduce. We don't know if we're going to work a bit more and then we go low. So it's very unpredictable from a day to another. But I tell my patients as many days as you can. It's better than nothing. At least you contribute and you try. So see here, taking the dose of insulin, look at the hyperglycemia, went up to 19. I think he corrected here. Again, if it's not documented, I don't know what's happening and they don't remember what they did. But then it stabilizes during the day and then in the evening, look, the blood sugar goes up with the food. Okay, the same thing, the blood sugar goes up with the food. Now here, they had to break the fast because they went low on the lower end. So they had to protect themselves, which is very important. Okay. And here we have a correction. The correction was on the stronger side because it brought it down to 4.5. So you have to be very careful to avoid those lows during the day. Now we're moving on to the manual pumps. So the manual pumps are right now on the market because that's going to change. Right now on the market, we have Omnipod and we have the older versions of Medtronic pumps. So we need to make sure that the basal during the day is a good basal. So do basal testing with your team. So the basal's job, if your blood sugar is at 8, you're supposed to stay at 8 all day ish, okay, all day long. So this is a good basal. The basal's job is not to get you from 12 to 8. Its job is to maintain you at the level of blood sugar to stay stable. So what we're gonna do, and this is what I encourage my patients, is to create a Ramadan basal to play in it. Because if we wanna, when we go back to our normal routine, we can't remember what was our settings before. So very important to have that Ramadan basal. And we can reduce it 10 to 30%, again, like the on injections. What I like with the pump is we're able to manage specific moments of the day with different basal settings, which lead us to when the last 3-4 hours of the fasting, our blood sugars goes down because it's the end of our maybe reserves of glucose from the liver, or we were more active. So we're going to reduce that basal 20 to 30%. And then because we're eating a bit more than usual, we can increase the basal at the iftar time. So to go compensate for that insulin resistance created by the fat or by the amount of carbohydrates we're having. So that those are options that we can work with. And we can also or use also a temporary basal minus 10 to 30% during the day when we're fasting. For the boluses, so for the meal and for the corrections, we take the boluses with the meal as usual. We don't eat, we don't take. there's a possibility on the pump to use the extended bolus. Okay, so the bolus, the amount of insulin we're taking for the meal, we can extend it on a period of time because the digestion is delayed by the fat and the protein that we're having on a bigger meal than usual. We might need to take many corrections during the night to bring back down the blood sugars and to compensate for a carb counting that is not precise or eating more dessert than usual. So it's important to keep correcting if needed. The meal of the morning is very important to be cautious because you don't want to start your day by breaking your fast because you're going low. So it's important to start with lesser dose, even though you're going to be higher. And then the next day you get to know, okay, this is how much I need. It could go either way because in the morning is our where the most insulin resistance usually, and we need more insulin for the same type of food. So this is where you have to try it out to see what do you really need. And during the day, we have to be careful with the corrections because if you overcorrect, you're gonna go low. And again, I prefer with the pump, it's easier because the pump will account for how much insulin you still have from the previous bolus. But please don't override the pump because if you override the pump, you're gonna go low. So this is an example. See, in the morning, the patient is taking a dose of insulin and then brings him down to the normal and spends the day relatively reasonably in target on the higher end, but he is in the green. And then I'm guessing here it's his liver that is saying, okay, enough. Let's bring more sugar. And then for the supper C, this is a patient that corrects and then eats, eats again, eats again. This is what we call insulin stacking. He ends up low. Okay, so keep that in mind. That happens, but here he can treat it. It's in the night. Okay, he can eat. So this is another example where the patient took a correction and it brought him down to normal on the lower end. So this is where we can discuss the target. Instead of the target being 5, we can put the target at 8 so we can correct less. Okay. And we can still hear he was on the higher end. He uses a more basal. So he increased his basal to bring his blood sugars down. So there's many options. You really have to sit and discuss it with your team to see which one fits you the most. Okay. Now we're going to talk about the automatic pumps. So we have right now 3 different algorithms on the market. So I'm going to talk about all 3 because the way we manage it is different. So we're going to start with the tandem pump. Again, we're basal insulin. We're going to create one and we're going to reduce it 20 to 30%. So we can use one or the other, or we can use both at the same time. We can put the exercise mode on for the duration of the fast. So the exercise mode brings our target to 8.9 instead of being 6.1. Even if you're on the higher end, it's okay. The pump anyways will correct you, but instead of bringing you down to 6.1, it will bring you down to 8.9. Okay. Now, this is my thinking. Do we remove the sleep mode at night? So the sleep mode, we don't have automatic corrections. That's why we put it for the night. So we don't get automatic corrections, but we know that we're eating bigger meals in the evening, higher carbs, and we need those corrections to kick in, especially if you're sleeping, this is where we can take out the sleep mode to be able to get those corrections hourly. And finally, if the blood sugars are higher than 14 during the day, it's very important to measure the ketones because on a pump, whether it's a normal pump, the manual pump, or an automatic pump, the being on a pump there is a risk of ketoacidosis because of the catheter. So if the catheter is kinked, you're not getting the insulin properly, then you're not getting the insulin, and this is where we build up ketones. So very important to be aware. And then if we're dehydrated because we're not able to drink water, so we mix both together, it's a risk. So have ketone strips blood ketone strips with you. And on the website of Better, you have the protocol either on injections or on pumps to be able to manage your ketones. And the symptoms, let's say you're not sure, we also have symptoms, nausea, vomiting, you're not feeling good, pain in the belly. It's very important to measure your ketones. Now, for the automatic tandem pump, what do we do for the boluses? So, what I like in the tandem is we can, in the Ramadan program, we can also have different carb ratios and different correction factors that maybe we want to tighten for the evening to get more corrections and get more for the food compared to normal days where we don't need that much. So that could be interesting. And again, we can reduce the correction during the day so we don't get as much corrections as usual. So for the iftar, we can increase our carb ratios to get more insulin and have more tighter correction. In the morning, then it's the other way around because we don't want you to go low. So this is an example. See here, this is a patient where she's having the exercise mode. And even with the exercise mode, she's on the lower end of the target and the pump is suspending most of the day. So this is a good example to create a basal that is lower than usual plus the exercise mode, okay? Compared to others here, look, I don't have the exercise mode and it's going well during the day and the pump is not stopping that much. And see in the evening, we really need to change the carb ratio. And here she's even correcting even more than what the pump is suggesting to catch this hyperglycemia. And see here, we're having a postprandial peak. So the blood sugar is rising after the meal and the pump is correcting, okay? Correcting to bring down. In this situation, we can loosen the correction so the pump doesn't suspend. Now we move on to the Medtronic family, 770 versus the 780. So it's very important to understand how the algorithm works. So the algorithm is based on whatever happens the 6 days before. So it's an average to give a basal and a correction. Keep in mind, we don't have any control over the basal with the 770 and the basal and the correction on the 780. We don't have a choice, okay? We don't control it. We cannot change it. So the pump decides the basal and the correction based on the average of the blood sugars and the needs of the past 6 days. So that's why it's very important to practice 1 to 2 weeks in advance to adapt that algorithm to what you're having. We can also use the temporary objective, so the temporary target, that is 8.3. And what's good in this pump at a temporary target at 8.3, we don't get automatic corrections, which is helpful so we don't crash if it's happening, if we don't want the pump to correct. So it depends on how we're managing the diabetes. Some patients, they need the corrections, some others, they don't need. So it depends, we adapt to the algorithm. And I lost my voice. Sorry. So this is for the basal and the corrections, okay? Now, for the meal boluses, we need to bolus all the carbs. That's non-negotiable because I don't want the algorithm to detect the rise of the blood sugars related to the carbs to detect it as a need for more basal, okay? So it's very important to bolus and to bolus before eating. You're not sure, just enter an approximate. The pump will correct you. It doesn't matter, okay? Doesn't have to be a precise carb count, okay? Sorry, I'm trying to see my, wait a second. I don't know what I wrote here. Okay, so we need to adjust the carb ratio, and I'll get to that. The carb ratio is different if we are on the 770 or we are on a 780, okay? So if we are on the 770, we are counting, there's no automatic corrections. We are counting on the carb ratio to give us more insulin. So we are going to tighten our carb ratios to get more insulin to cover the meal in the evening. And then we let the basal manage the rest. So see during the day here, the basal stopped completely. Most of, see how little insulin this patient needed. And even with the temporary target at 8.3. Look here, the basal is increasing quite a bit to go compensate for, the delayed digestion of certain meals. And here we have meals that are not covered. Here it's not covered, the meal is not covered, versus here the meal is covered after. So the risk of lows are higher because we gave the insulin after. See here the low here? So it's very important to be careful and take the insulin before eating. Now, if we move on to the 780, so the 780 also, it's an algorithm the past 6 days, but in this algorithm, we get automatic corrections. So this study showed that the algorithm adapts really fast, and the differences are really slight in the time and range change. There's not much hypoglycemia. The only thing that changed is how the insulin is distributed. So you'll get more insulin in the evening and less insulin in the day, which is not the case when we're eating during the day. But we still have the postprandial peak. See here, we have more. By the time the algorithm adapts, it takes a bit of time. So we're going to see that postprandial peak. Okay. And during the day, and this is my personal thinking, is during the day, if you are the type not bolusing your meal, your lunch meal, or your snacks, just be aware, just in case the algorithm gives you more basal and corrections those moments of the day. And then there's no carbs when you're not eating during the day. So the risk, you're going to get maybe more basal than you need. And then there is a risk. So I just want you to be aware that could happen. And this is a patient. See, she boluses here and here. So we need to manage the postprandial peaks. Now, on the 770, we need to tighten the carb ratios. On the 780, we need to make them looser because we want that correction and that basal to arrive earlier on after a bolus. So it's the other way around. It's another way of thinking. So please talk with your team to see how you need to move your carb ratios to manage your postprandial peak based on the algorithm you're using. Finally, I do have patients using other medication, other type 2 diabetes medication, either with their pump or with their injections. So the SGLT2 for Ziga, Invokana, Jardiance, dapagliflozin, empagliflozin, they have to be stopped because there's higher risk of DKA anyways with those medication, period. So you add dehydration on that, so there is a risk with it. So we stop them during the fasting, and blood sugars are going to be higher. I'm telling you. So be prepared for that because you're not peeing the extra sugar. We're going to keep the metformin if you're used to it. And then you're going to take it on the 2 meals, morning and the iftar one. GLP-1 is going to be Victoza, Ozempic, Trulicity, or Mounjaro. If you are already using it, no symptoms, you're feeling good with it, you can keep it. Otherwise, you have to discuss it with your team. And the DPP-4, Januvia, Onglyza, or Trajenta, you can keep them. There's no risk. In conclusion, so I hope Asma and I helped you to be able to put a plan or to ask the right questions to your team to be able to have that plan happening for you. Maybe it's not gonna be top notch this Ramadan, but as Ramadan comes back again and again, we can master the plan and tweak it and adjust it until it works for you. Okay. So it's important to prepare. It's important to have the teaching and the education related to that, to have the discussion with your team, to be able to manage those blood sugars optimally. I'm going to say optimally as many days as possible. This is what I tell my patients, as many days as possible. Okay. I didn't talk about the alarms. I didn't talk about the arrows, but we can manage based on the alarms that your CGM is providing you, on the arrows also, how you're correcting during the day if the high alarm is ringing, changing your dosages, which medication we can keep, which medication we have to stop, and then very important to break the fast if you are low. Unfortunately, we don't have a choice unless you have a sugar infusion, so it's not going through the mouth, it's going through the veins. So but that's not happening unless you're at the hospital. And then risk of ketoacidosis, because we don't want you also at the hospital because of the built up ketones. So here we go.
Thank you very much, Maha, Asma, for this great and detailed presentation. Thank you for those who are with us today. If you have any question, please submit them in the Q&A question. If you have any comments or if you want to share any strategies that you use, you can do so in the Q&A. While waiting, maybe I can tell you that our next event will be in March 24th, and we'll be talking about equitable access to diabetes technologies. So if you want to stay updated about the Better Project and our events, you can follow us on social medias and on our website also. So I don't know if you have any closing words, because I don't see any questions or comments. No? Oh,
Ramadan Kareem to everybody.
yeah, yeah. Well, I guess that's it then, if I don't have anything in the question and Q&A question. So thank you again, and please be with us for our next webinar in March. Thank you again, Asma and Ma.
Thank you.
Bye,
Thank you.
everyone.